Welcome to Mastering and Guideline in Ultrasound and Echo. As I mentioned in mitral regurgitation, any kind of the jet, doesn't matter regurgitation or stenosis or shunt, they have three components or three parts. Head, that we call it fluid convergence or PISA, neck or vena contracta, and body or jet area. It includes regurgitation or stenosis. Here you can see it. And the most important principle for getting correct continuous Doppler of the jet, any type of the jet, is one thing. Our cursor be as much as possible parallel to the neck of the jet. For example, here our cursor for doing this one is MR. We have to, if you want to measure VTI of MR, our cursor should be exactly parallel to the and pass through to the neck of the jet. Here you can see it should pass through this way. On this, for example, in another one, MR here, if we want to do continuous on the MR and catch it Doppler, our marker is here. If we put cursor here, is a little off axis. So we have to do some maneuver and go our probe a little this way that become more medial of the heart or medial of the patient too. We have to move medial a little and then put our probe here. Then cursor will be almost parallel to the jet. You cannot do continuous on this view because it's more than 20-degree misalignment between jet, neck, and your cursor. Or in this case is a little off-axis apical tree or low-axis plaques. As you can see, jet is eccentric posterior. So if you put continuous in this way, you are off and you are 100% underestimating. For that matter, we have to move our probe here, means move to the base of the heart or toward the shoulder of the patient, move it. In that case, probe come here and make it parallel to the jet, and our continuous Doppler will be perfect. Now let's see on the aorta what is going on with the aorta stenosis and how we use this concept for doing continuous Doppler of AS and what is the relevance between that and Pedoff probe. Like mitral regurgitation, aortic stenosis jet can be concentric or central and eccentric or out toward the walls, any of those direction. As you can see here, imagine this is our aortic valve and the direction of the jet can be any way. Here you are watching from front, you can see just imagine how much jet direction can be. In a large study, it showed that the neck of the jet or direction of the main jet or neck of the jet on the AS only will be captured and record on apical 4 in 40%. Even in those 40%, we have to do some maneuver, otherwise it drop. With maneuver, with transducer and the 2D transducer and Pedoff, only on the apical window we can record the highest velocity in only less than 40% of the cases. In other words, 40% of the cases jet this direction. Central, almost concentric central, a little left or right, but central. Imagine your probe is here, you can get it this jet that I am not showing here. The other 60%, 50% of that, we can record it on the right parasternal from up to the bottom. These two, for example, you can see instead of the pointing apical 4, pointing the jet looks like heading to the direction of the body of scapula, but in the other 50% pointing to the shoulder, to the back, side, or a little that way. and posterior. That is the reason we can alignment our ultrasound pulse to the neck of the jet in those areas. 10% of the rest we can record from the suprasternal notch, like you can imagine this one, suprasternal notch, and the 5% almost from subcostal, this jet. You put subcostal and you can make it parallel to that jet. So keep in your mind, this is the direction of the aortic stenosis turbulence jet. That is almost correspond with the neck of the turbulence. Now let's see how we practically can detect this 40% and this 50% by 2D transducer and Pedoff. Unfortunately, because of the sclerosing and calcification of aortic valve and the location of aortic valve in the apical window, most of the cases of aortic stenosis, we cannot see the turbulence and neck of the jet. We can see turbulence a little at the aortic valve, but we cannot figure it out what is exactly jet, where is the direction of the jet. But we have to give our best shot to see if we can see the jet. If we find the jet direction, it will be piece of cake to do maneuver and put continuous Doppler exactly over the jet. Here, there are 3 examples. These 3 cases, I can tell you, assure you, that almost are the best patient with the aortic stenosis has such a good window. Most of the cases of patient with aortic stenosis, image quality and window is horrible, and it makes our job worse. So you can see here, even we have very strong windows here, you can see, but you see up to the LVOT where AI, but you don't see any jet at the aorta. Or here in the apical 5, we see turbulence on LVOT and even before the valve, but after the aortic stenosis and valve, we don't see it. Here is very clear, strong window, but unfortunately, we cannot say the jet direction is where. Just we see turbulence, maybe, most probably, maybe is centric or central. Don't forget that because of the depth, it's decreased and sometimes is very severe stenosis. Maybe you don't see the jet. You have to play with your gain, with your scale, and try to find, if you can, any direction of the turbulence and jet. For working with Pedoff, first we have to learn and know professionally how to work with the 2D and get the best Doppler with 2D probe, and understand the direction of the jet and what maneuver we have to do, make our probe and cursor parallel to the jet. Then from that, when you learn, Pedoff will be piece of cake. Here imagine you have apical 4. We have 3 type of the jet. Here is the adult view. Here is a pediatric view. Those that are pediatric are very familiar. In pediatric, you are cutting and throwing top part and watching the bottom part from the front. So it's exactly, you can see aorta, direction, LVOT is the same, but on the adult, you have to reverse in your mind, as you can see. Now, here, we put our probe is at apical 4, exactly apex at the center, and LVOT, imagine the patient has a classic apical 4. Now, we have 3 situations. One here goes to this way, another to the right, another a little between them, and if we put cursor at the center of send it cursor at center of the probe, it passed through to the aorta and LVOT. You can see here none of those jets are parallel to the our cursor. So for example, if you want to get this jet parallel to the cursor, as you can see here, this jet, we have to move our transducer a little lateral here, lateral, and make our cursor almost parallel. Even they has been said up to 20%, 20 degrees, sorry. 20-degree misalignment with the jet and cursor is acceptable because underestimating is less than almost 5%, 6%. But I recommend everybody make it as much as possible parallel, and in over 90% of the cases with this small and simple maneuver we can make it parallel. So for this, just we go a little more lateral. If you put cursor exactly parallel this one, the middle one. If we want to get the other one, if we want to get this one, as you can see here, we want to make it parallel to this one that goes toward the LA. We go a little to the medial. Here you can see for the first one we move to the lateral, get it parallel to this one. Here we put maneuver a little, not too much, 1 centimeter or a little, then make it parallel. Here for that we just go a little medial. We move it to the medial of a patient and make it parallel to that jet. Here you can see medial in adult view, make it parallel to that jet. Very easy. For that one we have to go too much, but unfortunately we don't have windows here, and even in those cases apical we move a little lateral, we lose the window. That is the problem with the 2D image. Apical, when we go a little to the lateral, lung doesn't let us get view that we can see it and do continuous Doppler. Or the same as the other one, if we go medial, sometime lung or rib or sternum doesn't let us go move to the medial and try get it parallel to this jet, that it goes to the lateral. Here go to the medial of the patient, here lateral, here medial, you can see here. Now what about the situation that we don't see the jet? What we have to do? That is, the most cases actually is like that, as I show you. Even in the best case we can maybe see some jets, but most of the cases we don't see the direction of the jet. What we have to do for 2D probe is first try get it as much as possible your cursor parallel to the LVOT and aorta. Here is the aorta, as you can see. This is a little off axis because apex is to the left. We move a little lateral and make it almost parallel to the LVOT and aorta, almost. Now, my recommendation to you is this. First, get one Doppler on this center that is parallel and see the peak, how much the peak is. Then update your image with trackball, move your cursor from the medial to the lateral. So bring your cursor here and watch slowly, watch your Doppler and move slowly your marker to the center, then to the lateral, and see which spot has highest velocity. That spot is your window and correct Doppler on 2D imaging. Now let's go base after knowing this maneuver and jet direction, how we use probe, Pedoff probe, and catch our Doppler, continuous Doppler on those 4 windows: apical, subcostal, right parasternal, and suprasternal notch. Now, before we go to the technique, let's see when we have to use Pedoff. Generally, if the mean pressure gradient is over 20 millimercury, means the patient has moderate above stenosis, we have to do Pedoff. Only one condition we can ignore it, is that we see very clear good plaques, good PSACs, and we see those are finding gradient and other 2D finding, they match up and with this, even with the symptom of the patient. If the patient has symptomatic shortness of breath with activity, chest pain, all those stuff, even you have good image, you but still you have over 20, you have to do Pedoff. Second, aortic stenosis without obvious jet. If you see aortic calcified, sclerosing, and especially in PSACs and plaques and apical, all those three, there is evidence of stenosis, but you don't see jet clear on aortic valve, turbulence, you don't see it, we need Pedoff. Next one, when you have aortic stenotic based on 2D finding, but on Doppler you don't see very strong envelope like this patient, but this belongs to this patient. You don't see strong envelope, even gain is high on all the stuff. With this stenotic, you have to see and parallel. Your window is not bad, you have a strong window, but you don't have good envelope, strong envelope for the aortic valve. You have to do Pedoff. Actually, this patient had critical stenosis, not stenosis, critical, was less than 5 millimeter aortic valve area. Next one is when you have aortic valve bicuspid and there is some evidence of stenosis. The only time you don't need it that you can see on the PSACs and aortic and plaques that is opening very clear. You can see orifice of the aortic valve very obvious. In that case, you don't need it Pedoff. But in other case, if the patient has bicuspid aortic valve, a little calcification, and gradient is high over 10 to 15, you have to do Pedoff. When you see on the PSACs and plaques, aortic valve cusp doesn't open very well, as you can see here. Here you can see they are there. They are not opening. Even calcification not severe on this case, a little sclerotic, a little calcification, but not too much obvious, and you have good window. In this case, if you don't have gradient over severe on 2D, you have to do Pedoff. The next one, when you have severe calcification and you don't get it gradient high over 40, it doesn't show match up. In this case like that, severe, and you don't see any blood goes through even this part. It looks like open, this cusp, non-coronary cusp, but as you can see barely open and severe calcification. In this case, if on 2D you don't get high gradient based on this patient, I can say ejection fraction is very low, you have to do Pedoff. Another indication for using Pedoff for Doppler of an aorta is when we have aortic valve replacement, any type TAVR or any biometric or any of those mechanical, any of those, doesn't matter. And you don't see clear blood flow through the valve, like this one. This is TAVR, they did TAVR. I don't see any blood flow goes through, just here before the valve. After that, just some artifact or a little blood flow. In this case, you have to do. The only time on TAVR, you don't need to do Pedoff, that you can see through clear aortic valve, clear, and blood flow pass through that, and mean pressure gradient is not over 25 to 30 millimercury. Otherwise, we have to do Pedoff.